Hi there, my name is Muhammad and I'm a third year medical student studying in London, and if you're new here, welcome to my channel. So in today's video, we're going to talk about what happens in an anaphylactic shock. So in today's video, we're going over the definition of anaphylaxis and the causes of anaphylaxis and its pathophysiology, its clinical features, and how to identify someone who presents to A&D with a potential anaphylactic shock, and how to investigate the issue by going through the A to E approach, and finally how to manage the patient with anaphylactic shock. Okay, so first let's define what anaphylaxis is. So an anaphylactic shock is a severe allergic reaction that happens in the systemic circulation. So it's a severe allergic reaction that happens in the systemic circulation, and it causes shock. So what is shock exactly? So shock is hypotension with end organ damage. So there's a severe allergic reaction that happens in the systemic circulation that causes shock, that causes hypotension and end organ damage. Okay, so before talking about the pathophysiology of an anaphylactic shock, let's go through the causes of an anaphylactic shock. So what can cause an anaphylactic shock? Some drugs can cause an anaphylactic shock. Like what? Like penicillin. Penicillin. What else? Acetylcysteine. What else? IV contrast. People who are allergic to these drugs can potentially get an anaphylactic shock. What else can cause an anaphylactic shock? Certain types of food. Some people are allergic to fish, can get an anaphylactic shock. Nuts also, same thing. What else? Some people are allergic to latex, can get an anaphylactic shock. What else? Some specific types of venoms. Venoms. Venoms like what? Like bee stings. So there are numerous causes of anaphylaxis. Drugs, foods, latex, certain types of venoms like bee stings. Okay, so what is the pathophysiology of an anaphylactic shock? What exactly happens that causes these terrible symptoms that happen? Okay, so for example, someone who's allergic to penicillin, okay? Let's take penicillin as an example. This is a penicillin, this is the allergen basically. So penicillin is going to be ingested by that individual and enters the systemic circulation. When penicillin, okay, this is penicillin enters the systemic circulation. When it enters the systemic circulation, what happens? When it enters the systemic circulation, it gets recognized by a specific type of immune cell. What immune cell is this? This is a macrophage. And it also could be a dendritic cell. So this macrophage is going to come and engulf this allergen. So the allergen is going to come inside, and the macrophage is going to process the allergen. And what is it going to do with the allergen? It's going to come and it's going to put the allergen on its major histocompatibility complex type 2, or MHC2 complex. So MHC2. It's going to put it on the MHC2. And what's going to happen next? There's another type of immune cell that's going to come and bind to this MHC2 via its receptors. This is going to be a CD4 T helper cell. It has a T cell receptor, a TCR. It's going to go and bind to the MHC2. What's going to happen when the CD4 T cell goes and binds to the MHC2? It's going to start releasing different chemicals, mediators. What kind of mediators? So it's going to release different types of chemicals. What kind of mediators? For example, like interleukins. What kind? Like IL-4, IL-13. IL-4 and IL-13. Interleukin 4 and interleukin 13. what will these interleukins do? These interleukins, they're gonna go again to another type of immune cell. What type of immune cell is this? This is gonna be a B cell. It's gonna go to the B cell, okay? It's gonna go to the B cell, and it's gonna activate that B cell. When that B cell gets activated, it becomes a plasma cell. So it becomes a plasma cell when this B cell becomes activated. Okay, when that B cell becomes a plasma cell, and which is the active one, the plasma cell is gonna start releasing antibodies. What kind of antibodies? So it's gonna release antibodies. What kind? It's gonna release the IgE type of antibodies. What will these IgE antibodies do then? The IgE antibodies, they're gonna go, and they're gonna also go to a specific type of immune cell. This is gonna be a mast cell. What is the IgE antibody going to do when it goes to the mast cell? It's gonna go and bind to the surface of the mast cell. Okay? Specifically, it's going to bind to the Fc epsilon R1, Fc epsilon receptor 1. So the IgE will bind to this type of receptor, and this is gonna happen. Yeah. So IgE is gonna go and bind to the mast cell, and when this happens, the mast cell is said to be sensitized. The mast cell becomes sensitized. What does this mean? Sensitized. When the mast cell becomes sensitized, when the patient ingests penicillin again, this penicillin is going to go directly and goes and binds to these IgE molecules on the mast cell. When this reaction happens, the mast cell is going to start by releasing different chemicals, and one of the most important chemicals that the mast cell releases is going to be histamine. And we're going to talk about what histamine does in a bit. Histamine. So before we talk about what histamine does exactly, let's recap what we have just discussed. So the patient who is allergic to penicillin is going to ingest the penicillin, and this penicillin is going to be recognized by the macrophage or the dendritic cell. The macrophage is going to come and ingest the penicillin, and it's going to process it inside the macrophage, and it's going to come and put it on the MHC2 complex. Then the CD4 T cell is going to come and recognize it. Okay, it's going to come and recognize the allergen on the MHC2, releases mediators IL-4, IL-13, which is going to go and activate the B cell. The B cell becomes a plasma cell. The plasma cell releases IgE antibodies. IgE antibodies will come and stick to the mast cell, and the mast cell becomes sensitized. The mast cell becomes sensitized. What happens when the patient gets exposed to the same allergen again, penicillin? The mast cell is going to release mediators, and one of the important mediators that the mast cell releases is going to be histamine. Okay, so what are the effects of histamine? Histamine is going to have an effect on three main organs: the lungs, blood vessels, and the skin. So first, let's talk about what happens in the lungs. So in the lungs, the functional units of the lung is going to be the alveoli. And what is found above the alveoli? There are some airways that lead to the alveoli, right? And within these airways, there's a layer of smooth muscles. There are smooth muscle cells that function to contract and relax. When these smooth muscle cells contract, they are going to decrease the diameter of the airways, and vice versa. When they relax, the diameter of the airways are going to increase. So what will histamine do to the airways? Histamine, when it goes to the smooth muscle cells within the airways of the lungs, it's gonna cause bronchoconstriction. Bronchoconstriction. And what happens when there's bronchoconstriction? When there's bronchoconstriction, the diameter of the airways will reduce. Reduced airway diameter. So when the diameter of the airways reduce, the resistance to airflow is going to increase. There's increased resistance. You know what happens when there's increased resistance in the airways? You know when you go and auscultate the lungs, when you hear the sounds of the lungs, what are you gonna hear when there's increased resistance? You're gonna hear a wheeze. You're gonna hear wheezing. You're gonna hear wheezing of the lungs. Okay? So there's increased resistance. If there's increased resistance, it means that there's going to be reduced airflow to the alveoli. There's reduced gas flow. There's going to be reduced gas flow. What does this mean? There's going to be less oxygen in the alveoli, meaning that there's going to be reduced gas exchange. Less oxygen is going to enter the circulation because there's less oxygen in the alveoli. So we're going to end up with this thing called hypoxia, which is not good. Hypoxia, which is not good. So just to summarize, histamine is going to go to the airways. It's going to cause bronchoconstriction. The smooth muscles are going to contract, decreasing the airway diameter, increasing the resistance, and decreasing the gas flow. Less gas exchange is going to take place, leading to hypoxia. Okay, this is what happens in the lungs. So what happens now in the blood vessels? Two main things. The first thing that happens is that histamine is going to cause vasodilation of the blood vessels. Okay. What is the effect of this on the body? Well, so when the blood vessels become vasodilated, what's going to happen to the total peripheral resistance? The total peripheral resistance, or the TPR, is going to go down. We're going to have a reduced TPR. What happens if we have a reduced TPR? We're going to have a reduced blood pressure. And is having a good if we have a low blood pressure, is that good or bad? If it's too low, it's bad. Why? Because the perfusion of the organs isn't going to be good. If there's reduced perfusion, it means that there's going to be ischemia to the organs. If there's ischemia, there's potentially reduced oxygen going to these tissues, leading to anaerobic respiration. And if this continues in the long term, it's going to result in end organ damage. And we don't want that to happen. So basically, we end up with hypotension or a low blood pressure. What is the second thing that happens in blood vessels? Histamine causes blood vessels to become more leaky, increases leakiness of the blood vessels. Leakiness. Okay, if there's increased leakiness of the blood vessels, what's going to happen? If there's increased leakiness, more fluid from the blood vessels will move from the blood vessels and come into the interstitial spaces, causing further hypotension, further reduces the blood pressure, so less BP. What else? So if there's more fluid moving from the blood vessels and into the interstitial spaces, what's going to happen? There's going to be edema. There's increased edema. The patient is going to be edematous. What kind of edema are we going to have? We're going to have angioedema. It's basically edema that is under the skin, and we can see this around the eyes, around the mouth, okay, sometimes in the hand as well. What else? What kind of edema also happens? Laryngeal edema. When laryngeal edema happens, it causes airway obstruction. If there's going to be airway obstruction, less air is going to go to the lungs, and this is not good. And when there's laryngeal obstruction, we're going to see signs like stridor and hoarseness. The patient's voice is going to be hoarse because of what's happening. So there's increased leakiness and there's going to be vasodilation. Okay. And now, what happens in the skin? So in the skin, there's also going to be some skin reactions that are going to take place, like urticaria. What else? Erythema. And also the patient is going to have an itchy skin as well. Itchiness. Itchy. I can't spell. Itchiness. Okay. What else? The patient may also have rashes. Okay. So urticaria, erythema, itchiness, and rashes. Okay, 3 main effects on the lungs, and on the blood vessels, and on the skin. Okay, now, how will a patient who has a potential anaphylactic shock going to present when they come to A&E? And now we want to go over the A2E approach. What are we going to find in the airways of the patient? What are we going to find in B, which is breathing, and the circulation, disability, and exposure? Okay, so A is for airways. What are we going to find in a patient who is having an anaphylactic shock in their airways? So we just said there's going to be laryngeal edema, obstructing airflow, leading to things like stridor and a hoarse voice. Yeah, hoarseness. Cool. And then B, breathing. Okay. Now, we just discussed that there's going to be bronchoconstriction in the airways. And what is the effect of bronchoconstriction on the airways? What are we going to hear when we auscultate the lungs? We're going to hear wheezing. Okay. Because of the increased resistance, there's reduced gas flow, less air is going to go to the alveoli, less gas exchange will take place. Okay, if there's going to be less gas exchange taking place and less oxygen entering the bloodstream, how will the oxygen saturations be? The oxygen saturations will be low, yeah, low SpO2. And because there's going to be laryngeal obstruction due to the bronchoconstriction, there's less air going to the alveoli, less oxygen in the body, the patient's going to have so much trouble breathing. So the patient's going to be in respiratory distress, and they're going to be dyspneic. They're going to have a hard time breathing, respiratory distress and dyspnea. Okay. We're done airways, breathing. Now on to C. C is for circulation. What are we going to see? Okay. How we said that there's going to be vasodilation in the blood vessels of the patient. And how is their blood pressure going to be? They're going to, as we just said, the blood pressure is going to be low BP. So if the blood pressure is low, what's going to happen to the heart rate? You know, when the blood pressure is low, there are going to be some stretch receptors found in the carotid sinus, which are going to detect stretch. When they detect less stretch, they're going to increase the activation of the vasomotor center in the brainstem, increasing the activity of the sympathetic nervous system. So since there's going to be increased activity of the sympathetic nervous system, the heart rate is going to increase to try and compensate and increase the cardiac output to increase the blood pressure. But in this case, the compensation isn't going well. Yeah. Okay. So the increased heart rate is compensatory. Okay. Compensatory. Cool. What else are we gonna see in the circulation? You know, when we're gonna get an ABG, and in the ABG we're gonna see lactate, right? What's gonna happen to the lactate in shock? As we mentioned, that shock, the definition of shock is hypotension with end organ damage. If there's going to be end organ damage, there's going to be hypoxia, right? If there's going to be anaerobic respiration, what's going to happen to the levels of the lactate? Because of anaerobic respiration taking place, lactate levels are going to rise. So we're going to see a high lactate in the circulation. Cool. Okay, this is circulation. Now on to D. D is for disability. So disability is all about assessing neurological function. So how can we assess neurological function? We can assess the neurological function by assessing the patient by going through the GCS. How's the GCS in a patient with anaphylaxis? Okay, well, as we said, the patient is going to be hypotensive. Hypotension leads to reduced perfusion of the organs. Okay, reduced perfusion, what does this mean? How's the perfusion of the brain going to be? The perfusion of the brain is going to be really poor. So how's the consciousness of the patient going to be? The patient might potentially lose consciousness. So what does the GCS mean then? Is the GCS going to be high or low? the GCS is going to be low. The patient's going to potentially lose consciousness. So loss of consciousness. Cool. Consciousness because of reduced cerebral perfusion. There's going to be cerebral hypoperfusion. Cerebral hypoperfusion. Okay, next, exposure. What are we going to see when we expose the patient? We have just discussed like the skin reactions, yeah, urticaria, angioedema, rashes, itchiness, yeah. We can see these things when we expose the patient, okay? So, now we're done with the presentation. We went through the airways, breathing, circulation, disability, exposure. So how are we going to manage this patient who is suffering from an anaphylactic shock? So how are we gonna save their lives? So first thing that we can do, as we have just discussed, the SpO2 is low. So what can we give the patient? We can give them oxygen, right? Oxygen to increase their SpO2. What else can we give them as well? We can give them intramuscular adrenaline. Why do we give them intramuscular adrenaline? Okay, before that, the dose of the adrenaline for adults is going to be 0.5 mils, 1 in 1,000 for adults. Yeah. Okay, why do we give them adrenaline? First, let's see what adrenaline does. So, adrenaline, what will it do to the blood vessels? It's going to go and act on the blood vessels and it will cause vasoconstriction. Okay, vasoconstriction. How? Well, adrenaline is going to go and bind to the alpha-1 receptor on the vascular smooth muscle of the arterioles, alpha-1 receptor. Okay, and the reason why this is important is we just said that because of the histamine release, it causes what? It causes vasodilation. So when there's vasoconstriction, it increases the total peripheral resistance and increases the blood pressure. So this increases the BP, which is good, increases the perfusion of the organs. Okay, so what else will adrenaline do? Adrenaline will also go to the bronchial smooth muscles. And what will it do to the bronchial smooth muscles? It's going to go and bind to the beta-2 receptors and it will cause bronchodilation, reducing the diameter, reducing the diameter of the airways, reducing the resistance, and increasing airflow to the alveoli. Okay, bronchodilation via what receptors? The beta-2 receptor, beta-2 adeno receptor, beta-2 adrenergic. Beta-2 adrenergic receptor. Okay, cool. So adrenaline causes vasoconstriction and bronchodilation. What else can we give patients with an anaphylactic shock? You know, we just said that there's going to be too much histamine release. So how can we oppose the action of histamines? Well, we can give antihistamines. Antihistamines. Yeah, like chlorphenamine. Yeah, chlorphenamine. Okay. What else can we give the patient? We can give the patient steroids like hydrocortisone. As we just discussed, what happens in the anaphylactic shock is basically a huge allergic reaction, and an allergic reaction is an inflammatory response. So, what will a steroid do to this inflammatory response? It will reduce inflammation. Reduces inflammation. Okay. What else can we give the patient? Okay, we can give them IV fluids. Yeah. Yeah. Normal saline. 0.9% saline and 500 mils over 15 minutes. Yeah? Okay, what else? You know, some patients will also have a wheeze, and if the patient has a wheeze, then we treat these patients just like we treat patients who have an acute asthma exacerbation. So if there's a wheeze, treat like acute asthma exacerbation. So what do we give patients who have an acute asthma exacerbation? We can give them oxygen. What else? Salbutamol, ipratropium, aminophylline, yeah, and magnesium sulfate. So, oxygen, salbutamol, ipratropium, and hydrocortisone as well. You'd give them that. Hydrocortisone. So, oxygen, salbutamol, hydrocortisone, ipratropium, aminophylline, and magnesium sulfate. So, for managing and saving the life of a patient who is suffering from an anaphylactic shock, you give them oxygen, intramuscular adrenaline. Don't forget the dose for adults. Don't forget the dose for adults, 0.5 mils, 1 in 1,000. You give them antihistamines, hydrocortisone, IV fluids, and if they have a wheeze, you give them these drugs over here. Yeah. So that's it for today's video. I hope you found this video interesting, and if you enjoyed the video, please leave a like and subscribe for more videos, and I'll see you next time.